Hi everybody, welcome to Dr. Manny's YouTube Learnshops. Today in this session, this is about adult procedural sedation. Okay, as with all the Learnshops, they're intended for you, the nurses, and other healthcare professionals who essentially care for patients that are adults who require procedural sedation. Now in the past, the term has been conscious sedation or moderate sedation, which you can still use, but technically here now it's sedation associated with procedures. And these Learnshops, as with most of them here, will just provide an overview and review fundamentals which highlight some of your responsibilities and scope of practice. In addition to that, be aware that every organisation, healthcare organisation, has its own policy and procedures in relation to the medications that they administer. So therefore, these are just an overview. These are just generic doses and recommendations, which you will build on when you work with patients in your specific organisation. So what are the learning objectives for this session? Well, to review scope of practice and roles and responsibilities, look at patient assessment criteria before, during and after the procedure, look at the ASA Criteria, the MALLAMPATI Airway classification, look at certain sedation assessment tools, which there are numerous, in addition to patient assessment tools, which again are numerous depending on the age of your patient. We'll look at vital signs and common medication regimes, which are now not essentially the same as what you do in your healthcare organisation or your specific area. For example, in gerontology, they will be different to critical care, which may be different to oncology. We'll look at nursing assessment diagnosis and certain interventions, but by no means complete, just providing you with the essentials. So before we begin, let's look at your knowledge review. Let's see what you know. No, let's see what you think you know. Which level of procedural sedation will a patient respond normally to verbal stimulation? A, no sedation, minimal sedation, moderate sedation, or deep sedation? The correct answer is moderate sedation. Well, you could say no sedation as well, but we said who's receiving. No sedation, they're not receiving. Under what level of procedural sedation might a patient have inadequate spontaneous respirations? A, B, C, or D? Typically it's D, deep sedation. What level of procedural sedation may a patient only respond purposely to verbal, loud verbal, or tactile stimulation? A, B, C, or D? The correct answer, again, is deep sedation. What documentation is required prior to the administration of procedural sedation? And there's more. This is just an overview. A, B, C, or D? The correct answer is D. And more. What American Society of Anesthesiology, ASA, classification is a patient who has diabetes mellitus type 2 that's controlled by diet? 1, 2, 3, 4. There's 5 and 6 as well. But you've got 4 choices. The correct answer is ASA 2. What are the minimal monitoring requirements for procedural sedation? And there are more, but we're talking about minimal. Depends on where the patient is, what procedure they're having, and who's looking after them. Is it A, B, C, or D? The correct answer is D, but minimal is typically pulse oximetry. But I've included these all because this is what I believe should be the minimal, and many other academics. For procedural sedation, which of the following personnel are accountable, responsible for the patient's safety? The procedural physician, the physician who's not performing the procedure, the nurse who's busy with other patients, or the family member who's waiting? The correct answer is it's the procedural physician. They have to stay with the patient after induction of the procedural sedation and cannot go unless they've allocated the responsibility to another physician who's credentialed. Which benzodiazepines might or may be commonly used for procedural sedation? Diazepam, midazolam, lorazepam, or D? All. The correct answer is D. What narcotic is most commonly used for procedural sedation? Midazolam, fentanyl, morphine, naloxone. The correct answer is fentanyl. So when we look at the spectrum of sedation, we're talking about sedation essentially is the reduction of irritability or agitation and with pain control by the administration of medications generally to facilitate a medical procedure or a diagnostic procedure. And typically it's noxious. It might be unpleasant. Otherwise you wouldn't need to have procedural sedation. According to JCACO and the ASA, the sedation definition essentially consists of these. Minimal sedation, anxiolysis, which basically is reducing anxiety. So your patient can respond normally to verbal commands. Moderate sedation, conscious sedation, procedural sedation for less than 6 years of age. And look, there's no conscious sedation. It's a bad term. I mean, if you're sedated, you're not really conscious, you're not semi-conscious, you're not unconscious, but you're asleep. And if this is the situation, you respond purposefully to verbal commands and light touch. And you maintain your protective reflexes, so therefore your airway is maintained. You don't need assistance. If you migrate into deep sedation and analgesia, well, this is where you respond purposefully to repeated, loud, very loud verbal stimuli or painful stimuli. And there's a query. Are you really able to maintain your own airway and use your protective reflexes, which are cough, gag, and swallowing reflex? Most important is your cough reflex. Then you've got migration into general anesthesia. This is OR, really. And this is where you're unrousable to any loud stimuli, verbal, or any painful stimuli. However, you may have reflex withdrawal, you may not. You're totally, typically unresponsive. So when we look at procedural sedation, as I said, typically in the past it was referred to as conscious or moderate sedation, and this is a medically controlled state for a reduced level of consciousness in which the patient independently, one, responds purposely to verbal commands, or responds to your light touch. They can maintain a patent airway and they can breathe effectively. They don't need any BLS support. And there are no interventions that are required to maintain this patient airway or spontaneous ventilation. They have their 3 reflexes: cough, gag, and swallow. Most important one is cough, to protect their airway. Now, what is considered an ideal procedural sedation? And have a look. I'm emphasizing safety first. It's always safety first. It's safe. It's easy to administer. It has a rapid and reliable onset. It gets rid of pain. And it provides anxiolysis. It gets rid of any anxieties. And it's got minimal undesirable side effects. Look, there will be side effects. Typically here, it's to do with respiration. Your breathing becomes less, but it doesn't stop. And it doesn't become distressed. And the procedural sedation has to be reversible. There has to be an antidote. Otherwise, it could result in a problem for the patient. What are the patient benefits with procedural sedation? Well, the best are modification of consciousness or mood and perception of pain. It maintains consciousness and retains protective reflexes, cough, gag, swallowing. It relieves anxiety during the procedure. Gee, look, if you're having a needle inserted somewhere, femoral artery, central venous, it's distressing. Some people even get distressed by having an IV cannula inserted or blood taking. And in those situations, they may require procedural sedation, especially children, which you'll see if you review the pediatric procedural sedation Learnshop. There should be rapid onset of amnesia. You don't want the patient to remember what's happening, especially if it's potentially traumatic. There's decreased psychological trauma associated with the procedure, and there's minimal variation in your vital signs. You want the heart rate, blood pressure, respiratory rate, pain to be minimally affected. And as I said, it has to be safe, and there has to be a prompt recovery on the completion of the procedure. What are some of the undesirable effects of procedural sedation? The ones that you don't want? Well, you don't want them to be over-sedated, and you don't want them to be under-sedated. If they're over-sedated, this can initiate a whole lot of other undesirable effects. If they're under-sedated, well, they're going to have pain probably. They're going to be anxious, restless, uncooperative. Undesirable effects could include respiratory depression, respiratory failure as in apnea, airway obstruction. They can't protect their own airway. They can't maintain their own airway. Hypotension, bradycardia. It can cause arrhythmias and dysrhythmias, such as bradycardia, tachycardia. It can cause nausea and vomiting, which is one of the last things that you want in someone with a partially obstructed airway and loss of their gag, cough and swallowing reflexes. What are we talking about when we talk about over-sedation or under-sedation? Well, you know, over-sedation too much, under-sedation not enough. And this puts the patient who's receiving procedural sedation at risk. And you can have patients now, as demonstrated in the picture, pre-procedural anxiety. And if you're really, really anxious, then you may accidentally be ordered too much medication and be over-sedated. Or you may have such a great sense of fear and anxiety that the medication ordered isn't enough and under-sedated, and will typically result in you getting more or your patient getting more, and that could cause over-sedation. Then you've got obesity. Obesity, you've got a big person. And some of the medications are lipotrophic and lipophilic, which basically means the adipose cells, the fat cells, love the medication, and they'll take them out of the circulation, decreasing bioavailability, meaning what's available for sedation. So this can result in under-sedation. However, be aware, eventually the fat cells will release that medication, and this can result in over-sedation. Then you've got patients with hepatic comorbidities. The liver isn't working properly. One of the functions of the liver is to help with elimination, first pass, of these medications. And as a consequence of that, then the kidneys help excrete as well. But if you've got renal comorbidities, then these all can result in over-sedation and under-sedation and put your patients at risk. What are some of the contraindications? Well, some of the contraindications, potential, because remember, contraindications can be absolute, which means you definitely don't do it, or they can be, what's the word that I'm looking for? Relative, which means it depends on the doctor's decision. So the contraindications are that there's something wrong with the neurological system. You may have a level of depressed consciousness. You may have a raised intracranial pressure. However, having said that, you may have had a stroke and still require the procedure. And the doctor, physician, advanced practitioner may not want to cause you additional stress. So it's a relative contraindication. Absolute contraindication is when it can put you at harm. Your respiratory system. You may have an abnormal airway. You may have respiratory distress and failure. You may have an active respiratory tract infection. You may have a history of sleep apnea syndrome. Well, again, none of them could be absolute contraindications, but they could be. Some of them could be relative contraindications, which means someone at a higher authority, maybe an anesthesiologist, will make a decision about whether to proceed. Down syndrome patients could have an abnormal airway. Macroglossia, a huge tongue. They can't visualize the vocal cords. Intubation might be a problem if required in an emergency situation. You may have a history of cardiovascular disease. A lot of adults have got cardiovascular disease, and one of them could be related to the heart. Unstable angina, cardiac failure. However, it depends. I mean, you may have a patient now with unstable angina, for example, that requires to have a coronary angiogram, and this will require probably procedural sedation, because with a coronary angiogram, the femoral artery has to be punctured. A catheter has to be put and fed up into the descending aorta, into the aortic arch, into the coronary arteries. So, it's the physician and maybe an anesthesiologist which will make the decision in relation to that. Absolute contraindications and relative contraindications. Absolutely, not. Relatively, maybe. What are some of the stages of procedural sedation then? Well, you've got stage 1, as we mentioned previously, pre-sedation procedural assessment. Stage 2, intra-sedation procedural assessment. Stage 3, post-sedation procedural assessment. Stage 1 basically means the rationale is to identify high-risk patients pre-procedure and anticipate any issues to reduce adverse sedation events. Stage 2, the rationale is to identify potential problems that could occur or are occurring during the procedure and anticipate to reduce adverse sedation events. You may have to call a code blue. You may have to call a rapid response because you need help. You may need the antidote, which you don't have, which I hope you do have. Stage 3, the rationale is to identify patients at risk post-procedure before they are discharged and anticipate and reduce adverse sedation events so the patient can be discharged safely. So in stage 1, the pre-sedation assessment, there are medical responsibilities and there are nursing responsibilities. The medical responsibilities basically are, and there are a few more, I've just put the major, and it depends on your organisational policy as well. A current patient history, a current physical assessment. And most organisations state specifically within a 6-month period. There has to be informed consent and the physician has to determine the ASA classification. The physician has to do a focused airway assessment and there has to be a plan of sedation. The nursing responsibilities are to confirm that the patient's identity is correct, ensure consent was obtained for the correct procedure, make sure that the IV access is patent. All patients should really have IV access. Verify the patient's NPO status, that they've been fasting. Because again, even when you do everything correctly here, procedural sedation may result in the patient not being able to protect their own airway. And if that happens, God willing, their NPO status has been fasted for, depends on the procedure, 6, 12 or possibly 24 hours. And obtain baseline sedation score, pain score, and most importantly, vital signs. I'm going to review the medical pre-assessment responsibilities just to emphasise it. However, it's the nurse's responsibility as well to ensure that they have all been completed. The first one is, as I said, acquire a current patient history. There has to be a physical examination, and neither of these are allowed to be more than 6 months old because things can change when it comes to patient history and their physical examination. Establish the ASA status. Identify the MALLAMPATI score. Consider anaesthesia consultation if anything is identified as potentially being problematic or you have a concern. And this is important for nurses as well. So just because the doctor says, oh, gee, everything's okay, you may have a concern about their physical status and about their airway status. And there has to be a sedation plan. Is it going to be procedural, or should it really be a general anaesthetic? Then there has to be informed consent. I'm not going to go through what informed consent is, but typically it isn't really obtained effectively, correctly, according to the hospital policy in most organisations. When it comes to the ASA, Physical Status Classification System, the doctor has to determine at what level they are. I'll go through it briefly. ASA Physical Status 1 means you're healthy. You've got no physiological, psychological, physical abnormalities. You're a healthy person, which means that if you have the procedural sedation, you shouldn't develop any potential problems. You should have the procedure and nothing should happen. Should. Always be prepared. ASA Physical Status 2. This is when a patient has a mild systemic disease without any real limitations of their activities of daily living. So this could be a patient that has stable angina, controlled asthma, controlled hypertension, controlled diabetes mellitus type 1 and type 2. Then you've got ASA Physical Status 3. And this is where you've got severe systemic disease that really does limit your activities of daily living. And this can be uncontrolled angina. This can be uncontrolled hypertension, diabetes mellitus, cardiac failure, and more. And that puts the patient at risk if they have procedural sedation. ASA Patient Status 4. This is classed as being an incapacitating systemic disease that's potentially life-threatening. And if the patient now has procedural sedation, then it could put them at risk, code blue, etc. ASA Physical Assessment or Status 5, the patient is moribund and not expected to survive for the next 24 hours unless they get treatment. And ASA PS 6 is a brain dead patient whose organs are for donor purposes. This is the American Society of Anesthesiology's Physical Status Classification System, which has to be done and indicated at what level by the physician doing the procedure. So again, reviewing: 1, normal healthy patient; 2, mild systemic disease; 3, severe systemic disease; 4, severe systemic disease that's a constant threat to life; 5, patient's moribund, survival without operation or procedure is unlikely; 6, declared brain dead only for organ removal donation. So if the patient now is ASA 3 to 6, which is confirmed by the physician, then they have to be reviewed by an anesthesiologist. And the anesthesiologist will probably be there during the procedure, or they may decide on a different sedation plan, which could be here related to a general anaesthetic or others which are administered by an anesthesiologist. Another physician responsibility is to do a focused airway examination, and this is referred to as the MALLAMPATI score. And this is a classification based on assessing the distance from the tongue base to the roof of the mouth, and it's used to predict how easy it's going to be for the person, physician, responsible physician, to perform an endotracheal tube intubation in the event that something goes wrong. Patient can't protect their airway, they're obstructed. So you've got 4 classes. You've got class 1, 2, 3 and 4. Class 1 is the best because all aspects of the soft palate can be seen. Class 4 is the worst. Nothing can be seen, which makes intubation a little bit harder. In between you've got class 2, where you've got complete visualization of the uvula, but not the palatine tonsils. Class 3, you've only got the base of the uvula that you can see. You can't visualize the uvula effectively, the palatine tonsils, or the vocal cords. Class 1 is the best. And this could be related to conditions like Down syndrome, where you have adults with Down syndrome and they could have other potential problems which you identify. And it's not just the doctor, you as the nurse may identify that there are potential problems that the doctor has ignored. And you might say, look, doctor, I have a concern, this patient has a short neck. They've got very prominent teeth. They've got a retractable mandible. They don't seem to have a very mobile neck with an immobile temporomandibular joint. They may have an immobile cervical neck, or they may have other obstructions that you consider are important to point out to the doctor, the responsible physician, if they haven't identified them. Your responsibility as a patient advocate and to provide and promote patient safety. What are your nursing pre-assessment responsibilities specifically? Confirm the patient's identity. Ensure that consent was obtained correctly and everything was explained to the patient and their family. Ensure patient IV access is patent. Last thing that you want during an emergency is to realise that you've got a cannula that's now ineffective. It's tissued. It was never in the vein. Obtain relevant laboratory results to identify issues. They may be hypokalemic, hyperkalemic. They may have problems related to urea, creatinine, renal function, liver function, LFTs, etc. Because again, this will affect procedural sedation doses. Verify the patient's MPO status just in case something goes wrong and they can't protect their airway. They lose their effective reflexes. Cough, gag, swallow. Obtain a baseline sedation score, pain score and vital signs. Do temperature, do pulse, do respirations, do a blood pressure. Establish their pain score. Note their pulse oximetry. It's really important to identify the patient correctly. International Patient Safety Goal number 1. It's really important to ensure right patient, procedure, surgery. International Patient Safety Goal number 4. These two are the most commonly problematic international patient safety goals. We're not doing it. I don't know why, but we're not. Then we look at the Ramsey sedation scale, and this is just one tool. And the Ramsey sedation scale is simply something that allows a numerical score from 1 to 6 based on responsiveness of the patient. And the ideal level for procedural sedation is level 3, where the patient is sleeping comfortably, but with gentle voice tones. Dr. Manny, are you awake? Oh yeah, I'm awake. I'm alert. Are you cooperative? Yeah, sure, I'm really cooperative. I'll do whatever you want me to do. Okay, I really will. Because I'm at level 3 when it comes to the Ramsey sedation scale. Anything above awake and cooperative, you don't want them awake. Because if they're awake, they can see what's going on and maybe they may become anxious. Level 4 below, you don't want deep sedation, because then this requires painful stimuli, which means they could be moving further towards level 5 or 6. You want level 3. Then you've got the Richmond Agitation Sedation Score, or the RAS score. And this is now a medical scale used to measure the agitation or sedation level of a person as well. And it depends on your organisation or your area as to what you are using. And it was developed with efforts of different practitioners, which means multidisciplinary, not just doctors, and represented by physicians, nurses and pharmacists and other healthcare providers. And this basically says, in the moderate sedation, which is classified as -3, you've got movement of the eye opening to voice, but they sort of seem sleepy. They seem to be a little bit dissociated, so that they're not really aware about what's going on. Further, deep sedation, you don't want. Further up, light sedation, you don't want. You want them really sleepy. Then you've got pain scales, and I've just chosen these here. You've got the WILDA pain scale, and the WILDA pain scale basically is an approach that focuses on words to describe pain, intensity, location, duration, aggravating and alleviating factors. Words, W. Can you describe your pain? I, intensity. Well, how bad is it? And this is where you'll use a numerical scale, which you can see in the picture. 0 being no pain at all, 10 being the worst possible pain that they could possibly ever experience in their life. Location, where is it? Duration, how long have you had it? Oh, it's just happened? No, it's been there since we started the procedure 30 minutes ago. Well, why didn't you say something? Well, again, it's your responsibility as the nurse to determine all these aspects. The patient may not be willing to do so. They may be scared. Then you've got aggravating factors. What makes it worse? Alleviating factors. What makes it better? And this tool, WILDA, is used for individuals who can communicate effectively what their pain is like. And you don't preempt anything. You can see what you've got there. You can have aching, stabbing, tender, gnawing. You don't do that. You don't preempt their description. You just ask the patient to describe the pain, how bad it is, where it's located, how long they've had it, and what makes it better or worse. That's WILDA. Then you've got FLACC. FLACC is a scale of measurement that can be used for all patients, but it was designed for patients 2 months and 7 years of age. And basically it's about physical assessment. That's really what you're doing. You're looking at their face, because the face is typically the window to your soul. I mean, if you're happy, you'll have a smile. If you're unhappy, you won't have a smile. And this is typically for patients who are unable to communicate verbally their pain. And it's scored from 0 to 10. 0 representing no pain, 1 and 2 there, depending on which one you choose, represents their pain. So for example, legs. Well, gee, a person who's moving their legs all the time may be in pain. Or a person who's not moving their legs at all may be in pain. What's their activity? Are they restless, irritated, lying quietly? Are they crying? Believe me, adult patients can cry as well. If they're not crying, then they're probably okay. If they're awake, if they're asleep, you can be crying in your sleep as well. Are they consolable? Well, Dr. Manny, it's okay. Just wait for a few moments here and the medication should take an effect. I'll stay here with you, holding your hand, your wrist. I'll provide you with tender, loving care because I'm a nurse. It's my duty of care to comfort you. If Dr. Manny listens to that here now and believes that the nurse is a real patient advocate and cares about him, he'll probably be consoled. If he doesn't believe it, because she or he appears to be an uncaring person, then he won't be consoled. Each of the 5 categories, face, legs, activity, cry, consolability, is scored from 0 to 2, which results in a total score from 0 to 10. If you get 0, you're not doing your job. If you get 10, fantastic. Then you've got stage 2, Intra-Procedural monitoring. And all procedural sedation will be ordered and supervised by the privileged provider, which will typically be a physician, for all specific procedures. The ordering provider is authorised to provide procedural sedation, and they're grouped as follows. The provider is the person performing the procedure. They can also be an anaesthesia provider, which could be an anaesthetic nurse, if they're credentialed. It could be a qualified registered nurse, and who is being supervised by the qualified provider, which could be the physician, who also has to be credentialed, or it could be now an anaesthetic provider, who's an advanced practitioner, nurse, or otherwise. The provider performing the procedure must be present and immediately accessible at all times. They can't leave to go to the toilet unless someone else at their level is there to supervise and be accountable. And this is especially important when the sedation is being administered and continues to be administered. Monitoring of the sedation patient is to be a continuous procedure using the sedation score, and this will be dependent on the ASA, which we said typically is from level 1 and 2. Anything more than 3 requires anesthesiologic consult, depending on your organisational policy. When you monitor, we monitor the heart rate, blood pressure, respiratory rate, SpO2, pain score, level of consciousness, ECG monitoring, sometimes. Depends on the procedure. Capnography, which is entitled CO2 monitoring. Now that depends. That can be specific for patients who are at risk of retaining CO2, such as patients with chronic lung disease. Because remember, when you provide the sedation, there will be a degree of decreased ventilation, possibly not hyperventilation, but it could result. And if hyperventilation occurs and CO2 retention will occur, capnography is something that would be recommended. And you as the nurse might say, gee doctor, this patient's got chronic lung disease, he's got emphysema, he's got chronic bronchiolitis, he may be at risk of retaining CO2. Do you think capnography, entitled CO2 monitoring, is advisable? That's what you do as a patient advocate. Monitoring should start prior to the administration of the sedation, and vital signs are monitored every 5 to 15 minutes, really, during the procedure. Depends on the procedure, and it depends on the patient. Now we'll look at some of the medication options, and I haven't included them all. Most of them are here, but when we review medications, I'm only going to review a selected few. If you want more, you can review them. Google, the internet, server have got lots and lots of information for you. So inhalational agents include nitrous oxide, which includes oxygen sedation. You've got barbiturates, methotrexate, sodium thiopental. You've got benzodiazepines, which we're going to review, which could include diazepine, midazolam, lorazepam, and many, many, many more. You've got hypnotics, which could include chloral hydrate or ketamine. Ketamine is also a hypnotic, but I've put it under a different classification as a dissociative anesthetic agent. You've got opioids or narcotics, fentanyl, morphine, meperidine, alfentanil, sulfentanil. You've got other agents such as dexamethasone, antihistamines, hydroxamine, diphenhydramine, promethazine. And as I said, you've got dissociated anaesthetics such as ketamine. And you've also got anticholinergic agents which can be used in conjunction with others, such as atropine, to prevent things like bradycardia, which could be an adverse effect of some of these medications. What are some of the administration routes? Well, you've got numerous. I'm only going to focus probably on intramuscular, intravenous, and maybe intranasal. But administration routes could include oral, rectal, topical, intranasal, inhalational, sublingual, subcutaneous, intramuscular, intravenous, intrathecal, and transdermal. It depends. It depends on the physician, the procedure, the patient situation, and maybe even availability. When it comes to the benzodiazepines are considered to be relatively safe. They relieve anxiety, anxiolytic, they have a sedative effect, they have an analgesic effect to make you forget what you've experienced. And if required, they can have an anticonvulsive effect, but typically for procedural sedation, that isn't a requirement, but it could be, because some of your patients may be at risk of having seizures. The benzodiazepine that we're going to focus on is Midazolam. Midazolam is short-acting. Why do you use it? It's an anxiolytic, sedative, amnesic, and it can be used as an anesthetic adjunct. It is not an analgesic. There seems to be some confusion in healthcare providers. They seem to think Midazolam is an analgesic. So it's not an analgesic, and it will not provide pain relief during the procedure. They need another agent, an analgesic. What are the advantages? It's short half-life, so it's eliminated from the body fairly quickly. Be aware of that. They may need top-up. Significant antegrade amnesia, which basically means they forget what was happening prior. You don't want them to remember a traumatic experience. It relieves anxiety. What are some of the adverse effects? It can cause drowsiness, headache, because it can cause vasoconstriction, vasodilation, venodilation, nausea and vomiting. However, it does have minimal hemodynamic effects, minimal effects on respiration. It's important to be aware of the antidote, and it has to be there, available, just in case. Flumazenil is a benzodiazepine antidote. It's an agonist. It competitively inhibits the activity of the benzodiazepine and non-benzodiazepine substances that interact with the GABA receptors in the medulla oblongata in the brain. The purpose of this medication is to reverse the actions of the benzodiazepines. But remember, when you reverse it, they will wake up. Well, we hope they wake up. The dose typically is 0.1 to 0.2 milligrams intravenously, and this can be repeated every minute until there's reversal. The maximum dose should not exceed 2 milligrams. But remember, as I said, I'm just giving you an overview. I haven't given you any references. If you want references, I can provide them for you. However, you will go according to your organisational policy. That's what you need to do, because you will have an organisational policy that relates to procedural sedation. Make sure you follow it. Then you've got opioid narcotics. And the one I'm going to talk about is fentanyl citrate. And fentanyl is a powerful synthetic opioid analgesia. It's replaced morphine essentially. It's similar to morphine, but it's about 50, 80 times, 100 times more potent. And the purpose of this medication is to treat patients that are subjected to severe pain or manage pain after surgery or during the procedure, or in adults with chronic pain who are already physically tolerant to other opioids. What are the advantages? It makes you feel great, so I'm told. Euphoria. It relieves anxiety, and it's a very, very effective analgesia. It has a short half-life, so it's eliminated very, very quickly when required. However, look, it will be compromised by liver failure or liver dysfunction, renal failure, renal dysfunction. Adverse effects include drowsiness and confusion, level of consciousness changes such as unconsciousness, nausea, sometimes vomiting, constipation, absolutely, minimal hemodynamic effects and minimal respiratory depression effects. However, you may get respiratory depression and you may become hypotensive, but typically they are minimal and mild. So we need an antagonist. We need an antidote for narcotics, opioids. And naloxone, also known as Narcan, is an opioid antagonist, and it's used to prevent or reverse the effects of an opioid overdose, which could include respiratory depression, sedation and hypotension, which again may not typically occur with midazolam. It could though, however, occur with diazepam, lorazepam, some of the older first generation benzodiazepines. And the purpose of naloxone is to reverse the actions of the opioids, and the dose typically is 0.4 to 2 milligrams, and this can be given intravenously, immediate effect, intramuscular, probably an hour before it's effective, subcutaneously, probably 30 minutes, and this can be repeated every 2 to 3 minutes, PRN as required, but the maximum dose shouldn't exceed 10 milligrams or 0.01 milligrams per kg. But remember, your organisational policy will have a specific procedure, protocol for all these medications. Then you've got hypnotics or dissociative agents such as ketamine. Ketamine is a short-acting dissociative anesthetic agent that blocks sensory perception and induces a trance-like state. It's a very, very effective medication because it does everything, really. It's an analgesic, it's a sedative, it's an amnesic, it's a hypnotic, it can be used as an anesthetic adjunct. It's got a short half-life, provides very significant amnesia about anything that happened prior or during the procedure. It's a very good anxiolytic. However, be aware, it has adverse effects like agitation, dysphoria, confusion, dizziness, drowsiness. It can cause hallucinations. It can cause lethargy, coordination, and numbness. It can even cause chest pain. It's a vasodilator. It can cause tachycardia or bradycardia and hypertension. Typically, the cardiovascular side effects such as tachycardia and bradycardia aren't that specific, but it may cause tachycardia and it could cause hypertension. That's why it's such a good medication, because it doesn't affect respiration typically, and it doesn't affect your blood pressure. Whereas other medications that relate to procedural sedation can cause respiratory depression or it can cause hypotension. Ketamine typically doesn't do that. It may cause an increase in breathing rate and salivation. It may cause a tachycardia. It may cause hypertension. But typically, it may not. But you're aware of that. Ketamine doesn't have an antidote. So if you've given an overdose, you're going to have to probably intubate them, ventilate them, and send them to your post-anaesthetic care unit, or your intensive care if you don't have one, or your recovery area until they wake up. Now the loading dose for ketamine is typically 1 to 4.5 milligrams per kg, and it's given slowly over several minutes, and it's just given once. If it's given intramuscular, the dose is typically increased because again availability isn't going to be as good as with intravenous, which provides 100% bioavailability. Intramuscular, 6.5 to 13 milligrams per kg, just given once. Maintenance for intravenous can be 50% of the loading dose or you can give it specifically at 0.1 to 0.5 milligrams per minute as a continuous infusion. Now remember, the maximum single dose shouldn't exceed 0.01 milligrams per kg or 100 milligrams. But again, let me reinforce, there will be a specific protocol for your organisational policy. Now, you really should know your medication actions. So I've included this list here. So opioids, are they analgesics? Yes. Ketamine, is it an analgesic? Yes. Benzodiazepines, are they analgesics? No. Opioids, do they have a sedative action? Yes. Ketamine, does it have a sedative action? Well, again, I believe it does. Benzodiazepines, absolutely. Is there dissociation associated with opioids? Which basically means here, you're not aware of your surroundings. You are essentially in a state of flotation. You're feeling really, really good. Opioids, no. Ketamine, yes. Benzodiazepines, no. Does it affect the cardiovascular system? Opioids can have an effect on your cardiovascular system. Hypotension, tachycardia. Ketamine, well, again, it's the reverse. It can have an increased effect. Hypertension, tachycardia. Benzodiazepines can decrease the effect. Hypotension, maybe bradycardia, maybe tachycardia. Because remember, when you become hypotensive, you get a reflex tachycardia as a consequence. Respiratory, depression. Ketamine, no effect typically. Sometimes it can cause a little bit of bronchospasm, but it's a rare adverse effect, ketamine. Respiratory, benzodiazepines, it can have an effect. Respiratory depression, hopefully not failure. Liver, if you've got liver failure or renal failure, they can all accumulate. They can all accumulate and cause over-sedation. Is there an antidote for opioids? We said naloxone. Narcan. Is there an antidote for ketamine? None. Is there an antidote for benzodiazepines? Flumazenil is the antidote. Versed. Okay, now I think it's your turn. This is the knowledge review. Which of the following statements is true about fentanyl? A, B, C, or D? The correct answer is A. It's an analgesic. Which of the following statements is true about ketamine? A, it doesn't have an antidote. B, has an antiemetic effect. C, causes anuria. D, naloxone is the antidote. Ketamine does not have an antidote. Okay, which of the following statements is true about fentanyl? It's an analgesic. It can have a sedative action. Has naloxone as an antidote? Or is it all of the above? The correct answer is it's all of the above. Which of the following statements is true about opioids or narcotics? A, they depress the cardiovascular system. B, they can depress the respiratory system. C, it has naloxone as an antidote. Or D, it's all of them, all of the above. And the answer is all of the above. Which of the following statements is true about benzodiazepines? A, they can depress the cardiovascular system. They can depress the respiratory system. They have flumazenil as an antidote. Or it really involves all of them, all of the above. D. The correct answer is all of the above pertain to benzodiazepines. Which of the following statements is true about midazolam? It's an analgesic. It can cause polyuria. It doesn't have an antidote. Well, flumazenil is the antidote. So the correct answer is D. Flumazenil is the antidote. Now let's look at stage 3, post-sedation, which deals with monitoring and assessment. Now, post-sedation monitoring will be specific to the patient and the type of procedure done and your specific organisational policy. But generically, they're all very, very similar. And it should include level of consciousness, heart rate, blood pressure, respiratory rate, SpO2, sedation and pain score, from my perspective. It should include a modified or the ALDRETE score or the PARSAP score. And at least every 5 to 15 minutes for an hour, again depending on your policy, after the last dose of the procedural medication. Or for 2 hours after administration of a benzodiazepine or a narcotic reversal agent. Because remember, the reversal agent or the antagonist or the antidote won't last forever. And if you've got a huge dose still circulating in the circulation of your patient because they're obese or you've over-sedated them, then the antagonist will wear off before the medication and they can have a rebound effect on sedation, which you have to observe for. This is the modified ALDRETE score. And the modified ALDRETE score, or the ALDRETE score, named after an Italian physician, is an assessment tool used to evaluate patients following procedural sedation, and with the purpose to assess whether they can safely be discharged home or wherever they're going to be discharged to. Because it might be discharged to the ward, a general ward, and general ward nurses are busy. They may not be able to observe the patient continually, or they may be discharged home and your family members are not nurses. They don't recover patients. The higher the score, the more inclined the patient is ready for safe discharge. A score of greater than or equal to 9 is considered safe to initiate discharge. And you can see you've got respiration, colour, consciousness, circulation, activity. And depending on what you get, if you get 0 for everything, gee, they're not ready for discharge. You've got to get at least 9 or 10. Again, modified. There can be different variations of the ALDRETE score. But it's a tool to assess whether a patient is ready to be discharged, home or to a lower acute area, such as a general ward. Then you've got the PARSAP score, and this has been modified as well. And this is a pre-discharge tool which regards clinical conditions following day surgery or anaesthesia, patients who have received procedural sedation. For example, it includes vital signs, circulation, consciousness, bleeding, pain, and so on. And the variables are graded from 0 to 2, as with most of them, and you get a maximum score of 20. This is modified. The one that you're looking at here now, that is the real PARSAP score. I'll go back. The score has to be greater than 18 or equal to 18, which indicates recovery sufficient for home discharge. Now, it's really important before the patient is discharged that they're given instructions. And these are given to the patient and the family or the guardian. And the patient doesn't go home or to another area unless they have someone who can care for them. This could be the nurse, it could be a family member, it could be the guardian. And discharge instructions basically are the medications that they've received, the anaesthesia or sedation or both, and you explain to them here that this will affect your ability to think, to function, and make good decisions. And for your safety, you as the patient will need a responsible person to take you home or be present with you for the next 24 hours. And this could be in a general ward. This could be in a recovery area. And for the next 24 hours, you inform them if they're going home, you don't drive or use any machinery because you could injure yourself, you could kill yourself. Do not make important decisions, because if you make important decisions, then someone may empty your bank account or you may write over your property. Don't drink any alcohol. Now, you shouldn't drink any alcohol anyway. It's a toxic agent. But anyway, having said that, that's another time. Don't drink alcohol, especially if you're still taking prescription analgesia because you're going to be having a little bit of pain after your procedure, because the alcohol could affect the medication and make it a lot stronger. So let's review the knowledge before we conclude. This is your job. What antidote is used to reverse the effects of narcotics used in procedural sedation? Flumazenil, Naloxone, hydromorphone, or oxycodone? The correct answer is Naloxone. What antidote is used to reverse the effects of benzodiazepines used in procedural sedation? Flumazenil, Naloxone, hydromorphone, oxycodone? The correct answer is Flumazenil. In order to be discharged, a patient must have which of the following criteria? Stable vital signs, be alert and orientated as they were at their baseline pre-procedure, have a PARSAP score of greater than or equal to 18, or should it be all of them? It should be all of them, and more. What is the initial intervention when a patient receiving procedural sedation has got a decreasing SpO2 secondary to an obstructed airway? What do you do if they suddenly become hypoxic and they're obstructing their airway? Do you increase the oxygen flow rate? Do you open the airway using the head tilt chin lift maneuver? Do you administer 0.4 milligrams of IV naloxone? Or do you cardiovert them with 200 joules? What do you think? Common sense should tell you it's a BLS procedure. You open the airway with the head tilt chin lift maneuver. When a patient is receiving procedural sedation and they become unresponsive to painful stimuli, your initial treatment must be focused on which of the following? BLS and the reversal with the antidote, a bolus of IV fluid and vasopressors such as epinephrine, oxygen administration via a face mask, or 0.2 milligrams of IV flumazenil. It's BLS and reversal with an antidote. Look, you could even activate your rapid response team or call Code Blue if you were really worried. What dose of flumazenil should be used to reverse a benzodiazepine overdose in a patient receiving procedural sedation? Now remember, this is just a generic answer. You will have a specific answer with your organisational policy, but have a look. It's pretty straightforward. 12 milligrams, 0.2 milligrams, 5 milligrams, or 100 milligrams. The correct answer is 0.2 milligrams IV. What dose of fentanyl should be used initially in a patient receiving procedural sedation? A, B, C, or none of them are correct. The correct answer is B, 25 to 75 micrograms. Which of the following are types of tools for assessing patient procedural sedation? The Ramsey score, the RASS score, the innovation sedation score, or can you use all of them? You can use all of them. Depends on your organisational policy. Which of the following are types of pain assessment tools that may be used for patient procedural sedation? WILDA, the numerical score, FLACC, or can all of them be used? All of them can be used. And there are more. Which of the following medications and dose should be used initially to reverse the effects of narcotics? Is it 1 milligram of IV Midazolam, 0.8 milligrams of IV Naloxone, 1 milligram of IV hydromorphone, 0.2 milligrams of IV flumazenil? The correct answer is 0.8 milligrams of IV naloxone. Okay, that comes to the end of procedural sedation in this Learnshop for adults. Now, if you want to see something a little bit different, but similar, but different, look at the pediatric Learnshop. Thanks a lot. and I hope I see you again. And look, if you found this of any value, I would really appreciate that you pass it on to your colleagues, because the objective is to make us all safe, effective patient advocates for our patients.